I think that's a great approach. That's what we try to do with everybody in the Whiplash group, is have that team approach. That we're all a piece of the puzzle to help this patient get the maximum medical improvement. And when we're documenting and we're communicating, like you're saying, rather than just even the reports. Some people don't even share the reports. I think we should always, when we see a doc, send a report back to the doctor that referred them to us, so that we just have that congruency between the providers, which of course paves the way for the attorneys to just,
that's right,
they've got all the documentation. They need to really take care of that patient.
Yeah, we're just so much stronger when we when we communicate with each other, and it's that little extra step, right? But it makes a huge difference for the care of the patients that we're seeing.
Hi, Dr. Shetlin, Whiplash Group members. Thanks for joining us, and any other doctors and attorneys that may be joining us for this. I want to introduce you to Dr. Courtland Keteyina. And he is joining us. He's a member of the Whiplash Group, and he practices in multiple states. So he is going to explain some of the amazing regenerative medicine things that he specializes in to help us help our patients better and our clients better, and wrapping up cases and making sure they get better and have long-term benefits rather than just a short-term symptom satisfaction that then chronic problems gear up later. We want to make sure that us as doctors are first doing no harm by treating to fruition and maximum medical improvement, not just treating to wrap up a case and move it on. So I love how he is philosophically grounded with us on ethics and professionalism. So Dr. Courtland, take it away.
Thank you, Dr. Shetlin, and great for the opportunity to be here and speak with the group. So I'm going to talk today about both ultrasound and then regenerative medicine, both of which are near and dear to my heart, and I think also work really well together and can be extremely supportive for the types of care that we are providing within this group. So first, just a little bit about me. Again, I'm Courtland Keteyina, and my location there in Utah is with Optimize, which is in Murray, and I work with a group of chiropractors there, and do a practice that focuses on regenerative medicine and ultrasound. Just for some context, I did a fellowship in occupational medicine that was at the University of Colorado, so I have a lot of experience treating individuals who have work-related injuries, also a lot of PI as part of that training program. My residency was at the University of Michigan in preventive medicine. That's also where I went to medical school. And then really rewinding, my undergrad was at Yale University. I majored in molecular biology, and so my interest in really kind of cellular-based opportunities for healing folks started way back when I was an undergrad. And then I have a specific certification in diagnostic ultrasound, and spend a lot of my time teaching other physicians, whether that's sports medicine or occupational medicine, usually, who are trying to learn ultrasound techniques for their practices, and that's the RMSK certification. I don't have anything to disclose. I don't have any conflicts of interest. So just to talk about first, what is diagnostic ultrasound? This is a field that has been really evolving rapidly in the last 10 to 15 years. Technology we have today, we really didn't even have 5 to 10 years ago. Generally speaking, it's a non-invasive imaging technique, can be used to image pretty much anything in the body, muscles, bones, tendons, ligaments, soft tissue, nerve structures. It's using high frequency sound waves, so it's a sonar based approach to imaging basically. And it's quick and it's dynamic and it's in the office. So historically, where I used to have to send somebody out for a CT or an MRI, patient has to go to a different location. I have to wait for a radiologist to read the image. Now I just get to do that right in my office. Patients love it, right? Because they get an answer right on the spot, and it's dynamic. So I can have the patients moving, doing other things to really kind of elicit some of those symptoms, which I wouldn't have been able to do in a static imaging environment like an MRI or a CT or even X-ray. So there's a lot of benefits then to diagnostic ultrasound, and I've listed a whole bunch, but I'm going to kind of go over some of the highlights. There's, first of all, just real-time nature, and that is, again, dynamic. So if I'm looking for somebody that I think may have like an impingement of the rotator cuff, I can actually look at the rotator cuff slide under the acromion, see if that bunching of the tissue is happening, and really be able to cinch that diagnosis in real time. There's no radiation, right? So I'm not exposing anybody to any risk of radiation or causing any harm to them in that way. It's just high-frequency sound waves. Patients usually don't feel anything other than just the pressure of the transducer. It's very high resolution.
If somebody has, if somebody has a fracture, even a hairline fracture, that it's very sensitive to sound and vibration. Do you have any problems with that?
None at all. Yeah, none at all. And I've done that experiment on myself actually. I had a tuft fracture of a finger, and from doing a dumb project in the garage, and so was able to image that myself, and could see the disconnect there in the distal phalanx, and the imaging itself didn't hurt at all, right? There's no really tissue vibration or any damage from that.
Nice,
great question. Again, generally speaking, then resolution's very good. If you think about an MRI machine, it takes slices, usually 3 to 5 millimeters, depending on the technology or the size of the magnet. Ultrasound imaging is continuous. There's no slice. You're seeing all of the tissue based on where you're holding the transducer, really 1 millimeter slice at a time. Very convenient, available, point of care, and in the office, right? I can kind of do it with the patient right there, get an answer right away. It's also very cost effective. So the price of an MRI, right, when you're especially in a hospital or facility setting, $1,000 plus, right, $1,500 more than that. Ultrasound is usually paid for around $200, so it's much less expensive to perform. Payers like it for that reason. And then the last part is we'll talk about as we get into the regenerative piece. Very, very important for injections and guiding procedures. This has been studied now just in the extreme, and it's kind of a closed case that doing procedures with ultrasound significantly more accurate, fewer complications, less likely to nick a nerve or something like that when you're doing the procedure. So it's a very, very important adjunct for a lot of different types of procedures.
A lot of great benefits. That's awesome.
The thing that people ask me all the time is, what do you use it for, and what can you scan? And so I've just listed a few different areas. I think ultrasound's very, very strong in the extremities in particular, and so shoulder, elbow, wrist, and hand. That's very, very common and easy to use ultrasound. And then we get to lower extremities in the MSK world, hip and knee, foot, ankle. I mean, really everything, right? There are some opportunities with spine as well. And I know that's obviously of interest in the chiropractic environment. I think MRI is really kind of the gold standard if you're looking at disc pathology, facet pathology, things like that. But ultrasound can be very useful for procedures, medial branch blocks, things like that. So there's a lot of information I can get about the spine, even if you can't see the disc specifically or the facet joint specifically.
So doctor, would you say this is more beneficial, say for a shoulder? Because I know shoulders are often overlooked in the personal injury world.
Yeah.
But when the hand's on the steering wheel, those wrists and those shoulders are definitely exposed to a shear force through them. And sometimes those don't show up till later. They're worried about their neck pain or their headaches or maybe low back from that 3-point harness. But shoulders, they just go under the radar sometimes. I know some of the attorneys like, hey, they mentioned to us that the shoulder is hurting. Maybe they didn't mention to you, doc, we should get an MRI. Where does this rank in comparison to the MRI as far as what you're looking for in a shoulder, for example? It's
what the literature would say is that it's operator dependent, right? So if you have people that are really experts in the world of ultrasound, ultrasound is as good or better than MRI. And the kind of key issue that I mentioned earlier was the slice size of an MRI. So I see patients all the time where they've had an MRI, MRI's read as normal or maybe some tendinosis, and then I scan them and they have like a 4 millimeter partial thickness rotator cuff tear. And it's not that the radiologist missed anything, it's just that the imaging technology, right, of the MRI just missed it. It was the tear was too small, the slice was at the wrong angle, so they couldn't see it. So so that's one part. The other piece is the dynamic nature. So if you're looking for impingement or looking for just kind of range of motion specific findings, you can really see that on ultrasound, where an MRI, there's just no way to tell. You have to suppose whether somebody has, do they have a type 2 acromion or something that's causing it. Those are all kind of inferred as opposed to actually identified right in front of you. And the patients see it, right? You can point out on the screen and they'll see that this is the tissue sliding, and they get a sense of what's going on in their bodies. Yeah, the other thing worth noting is nerves, because this is an area that's been really, especially with the upper extremity injuries, this has been an area that has just started to explode within the world of ultrasound. And I'll routinely scan now nerve roots coming out, really the proximal brachial plexus, all the way down. You can do a whole nerve study of the entire upper extremity, and so get a pretty good sense. Somebody may have a thoracic outlet syndrome or a plexopathy. These are things we can start to look for on ultrasound, all the way down to a carpal tunnel syndrome. Ultrasound's a much easier way to diagnose median nerve entrapment than send someone for an EMG and have them get poked a bunch of times. So there's a lot of things we can just do again right there in the office, and it's challenging to do a full extremity nerve study in ultrasound or in MRI, but with ultrasound we can kind of really walk a patient right through that in the office and really get a lot of information. So there's tons and tons of opportunity with nerves, and we're just kind of scratching the surface still, kind of as a profession of sonographers. So I also included a few different images because I wanted to be able just to share what does this look like to not just me taking the image, but also to the patient in the office. And this was just an example of a gentleman that had an upper extremity injury, right? One of those shoulder type injuries, and just to kind of get you a sense of what this looks like in clinic. And so you can see the kind of definition around this is proximal humerus, right? Humeral head. That big white arrow on the top right points towards a bicep tendon. So you get a sense we can see overlying the subscapularis, the deltoid, the bone here, all that structure. And then what this transducer is doing is basically sliding distally down the arm. So you can see the red line kind of tracking. And at the bottom end, those arrowheads are pointing towards the pec major tendon. And I've had a number of these where somebody may get a shoulder MRI that's kind of outside of the range of what the image is looking for. The radiologist isn't looking for pec tendon injury for a shoulder order. And then I'll find a pec tendon that's disrupted. And that's an emergency. Those have to get fixed within about 30 days. And so this is one of those types of things, right? And the patient, by the way, right, they're telling me the whole time, they're like, doc, it hurts over here, right? Like it's not up there, right? And so I'm like, okay, well, let me just stick my transducer where you're telling me that it hurts. And let's see if we can identify that for you, right, real time here in the office. So it's a very different, kind of augmentation of the physical exam than may happen otherwise. And then I also wanted to show what a tear looks like. So this was a really good example. This was a supraspinatus image on a patient I had where we took a shot, and you can see there's a little black hole there on the tendon, and that's I would be considered a low grade articular sided partial thickness tear. It measures 0.33 centimeters by 0.18, so it's a 3.3 by 1.8 millimeter tear. Not big, but definitely enough that the person was uncomfortable, right? And so it's actually these small tears, believe it or not, that hurt the most. The folks that have like completely avulsed the rotator cuff and can't lift their arm, they're like, I feel fine, but they can't move their arm above their, at all because nothing's connected. But these guys that have these little 1 to 2 millimeter tears full of fluid, they're uncomfortable. They can't sleep. They're the ones that come in holding their arm across their chest. So that's really kind of the full idea. Patient comes in, we can identify this in the office, and this is a treatable problem, which is what we're gonna get to next. So,
well, I think it's neat that you can see this so clearly, because I'm looking at the image going, yeah, I can see it because you pointed it out, but you've got eagle eyes on this. But I also think it's fascinating how it's unlike an MRI where you're just laying there taking slices of pictures. You're interactive with the patient. You're able to move things while you're using your instrument of discovery. So I think it's fascinating.
It really changes the interaction with the patient, right? Because instead of them coming into the office with a test that has been done, and you're maybe looking through some images or through a report, right? They're telling you this is where it hurts, and then I can confirm for them on the screen, right? To say this is what we see, right? Move this way. Does that hurt? And we can even, because this is actually one of the really important things from my perspective. If we're going to do a regenerative procedure, we got to know the thing that's causing the pain, right? Hard to tell that if my imaging isn't connected to my experience with the patient. And so what I'll often do is we'll inject just some anesthetic, maybe a little lidocaine, into that defect in the rotator cuff. And the patient will start moving their arm around all over, and say, hey, that feels better. And then I can say, okay, great, bingo, that's the place. Now let's drop a regenerative treatment into that tear so we know that that's going to fix your problem, right? And you get people with these complex shoulder, neck, arm, the pain's all over the place. So we got to really be specific on what is the thing we're treating. And that's part of what ultrasound really can help us do. So now I'm going to talk some about regenerative medicine. And these things are it's like peanut butter and jelly, right? Like they just go better together, the ultrasound and the regenerative medicine. So if we just start kind of high level, what is regenerative medicine? It's really focused on either repairing, replacing damaged tissue or organ. It's big field. We're going to obviously focus on the kind of the orthopedic side of things here today. And it's a spectrum of modalities. And I think about this in 3 general buckets. I think about the prolotherapy and the prolozone side. Then there's platelet-rich plasma or PRP. and then stem cells. And stem cells all by itself, I think, is kind of a vast category. So we're just gonna kind of touch on the highlights of each of these, just to help people kind of understand where and when we might want to use each one. So with prolotherapy, there's a lot of things people call or may call prolotherapy. That their traditional sort of formulation, I guess, is to use dextrose. That's thought of as like the key ingredient, and it's an irritant. It's thought to cause a bit of an osmotic injury to the area where you inject it, and we're really trying to leverage the body's own like normal natural healing process, create some inflammation, flare things up, and then the body comes in and heals it. There's some folks that use different homeopathic ingredients with this, vitamins, B vitamins, and I actually use growth hormone with mine. So we kind of mix in different things depending on what we're trying to achieve. I'm trying to upregulate IGF-1, which is what tells cells we're going to lay down new collagen. So that's why I have the growth hormone. But there's lots of different things people use. But dextrose is like the key ingredient. The sweet spot for prolo tends to be ligament injury in joints. So I think it's a home run for low back that's like especially SI mediated, where people actually have pain. Instead of injecting into the joint, right? It's actually the ligamentous structures around that part of the spine that are connecting the pelvis and the sacrum. So iliolumbar ligament, long dorsal ligament, those types of things. Prolo is just dynamite for those types of injuries.
Well, correct me if I'm wrong. It seems like in applying this to motor vehicle collisions, a lot of times that 3-point harness will torque that SI joint, and we'll get a hypermobility in that, and that gets overlooked a lot. Where if you're able to, so instead of just staying hypermobile, so we've got a ligament instability now, which is very common in the neck after a whiplash. That's that on that grading system of the Croft guidelines, grade 3 and higher, they've got ligament instability. Well, we're adjusting them, we're doing physical therapy and massage, and those help with mobility. But if those scar tissues aren't healing up properly, they're not being guided, they're just going to form super glue. It sounds like the prolotherapy is helping to accelerate that, but then under therapy with massage and physical therapy, chiropractic, it's now laying down healthy tissue that it wasn't going to do. It's just going to stay torn, but the prolotherapy stimulates scar tissue where we need it, but we just want to guide it. Am I on the right?
I think that's exactly. Yeah, you're I think describing that exactly correctly. We're guiding the body to heal those structures, and the insult could be a number of things, right? I mean, in this environment, we're talking about auto, right? MVC, high velocity type injuries. I have a lot of patients, women whose pelvis is stretched for childbirth, right? They don't go back exactly the way that they were there originally, and so a lot of prolo to the pelvis, into the SI joints, etc. So there's kind of a number of things, but the idea is that we've stretched it. And if you in the prolotherapy world, the concept is called biotensegrity, and it's this idea of trying to create structure and stability through the ligamentous system of the body. So you're absolutely right. And you mentioned low back, obviously a lot of whiplash injury in this population, and cervical prolotherapy is done very frequently for folks that have those ligamentous injuries to the neck. Very, very effective at helping reintroduce stability in that area, and then reducing pain. The other thing I wanted to call out here was that everybody talks about prolozone, and prolozone is quite literally just the traditional prolotherapy, plus we then add ozone gas to it. That was a gentleman, Frank Schallenberger, who came up with that concept. And the idea of the ozone is to really kind of help accelerate the metabolic process of the mitochondria, help sort of boost ATP production, get the cells to heal faster. And it's really become kind of a standby when folks do prolotherapy. So when I do it, I'll actually do one injection with the prolotherapy first, and then it's like an ozone chaser. Essentially, it's a second syringe full of ozone gas. So it's often a little bit of surprise for people, right? We don't usually get injected with gas, but it does tend to be very, very effective. And patients will note that their pain, there's some pain from the injection, right, for a day or two. They tend to bounce back much faster when we use ozone with it. The last thing I wanted to call out on the prolo front was this has been around for a long time, right? Prolotherapy has been a field it's been 75 plus years at this point that folks have known about this. The sort of this book, The Principles of Prolotherapy, is kind of the Bible for prolotherapists. And I have to kind of give credit here. So I was very fortunate. The lead author on this, Tom Raven, is in Denver. And when I did my fellowship there, I was able to spend a lot of time, and he was extremely generous with his time and helping train. And so very, very fortunate to have that experience. And then the second author, Mark Keteyina, was the first one who did prolotherapy on me. I was his patient, and that's where I first got the bug that, this is really cool. And he's in Indiana. So feel very fortunate that I was able to kind of touch two of the people or be touched by two of the people that really kind of the authors of the modern day field. So I'm very, very, very fortunate for that. The next thing I wanted to talk about now is PRP, or platelet-rich plasma. Everybody probably has heard of this. There's PRP popping up on every corner, right? Everybody's doing PRP now. It's a great technology. It really, really is. For those of us that have been doing it for 10 plus years, we've seen the field really, really evolve in a way that's very positive. And it helps a lot of people. The idea with PRP is that we're going to take an individual's own blood, process that, and then extract the kind of the high growth factor, high potency component, which is the platelets. There's about a half dozen growth factors that have been identified in platelets that we know of that are really kind of high yield in terms of their growth potential. Platelet-derived growth factor, transforming growth factor. The VEGF is a pro-angiogenic, so that brings new blood supply. So that's all in the platelets. We're going to concentrate that all down. And the way I describe this to patients is you think of it like an injury where you're forming a scab, right? The platelets are going to come and they're going to bunch together and they release these growth factors. So we're just going to take all of that and put it into where this tear is or this injury is inside the body. Most of those growth factors are released very quickly within the first 10 minutes of depositing the platelets in the area of injury. And there's kind of subcategories. So we can make this as leukocyte rich, which tends to be used more on soft tissues, or leukocyte poor, where we'll actually go into the joint. It's really essential, and this is one of the things that's an important question to ask for this audience, is when you're sending someone somewhere for PRP, how are they constructing the PRP? Because providers will say, I do PRP, but the trick with the PRP is it's the cell counts, right? It's the concentration of platelets you're getting. And you really have to use, there's companies that produce these kits, specialized centrifuges that you use to make up the PRP, and they guarantee that you're going to get the density of platelets. And so, and there's a number of companies that do it. MSite is the company I use. Regenerative is kind of a big nationwide company. So there's a number that do it, but it's a really important question to ask, is to kind of make sure what is the system that's being used for the PRP to make sure that the patient's getting those high counts for platelets. Used for a lot of different things. Same things we use prolotherapy for, can be used for joints, tendon, ligament type injuries. The other thing to note with PRP is it can hurt. So that's something where I'll actually immobilize my folks, whatever joint I treat, for a few days, really let the PRP kind of sit in and heal. And then that really seems to give us the best results. And so very, very good treatment, requires a little bit of immobilization, and very positive. We've seen more of this come out. Definitely want to be aware of what is the production method, right, that's being used to produce it. So let's talk about stem cells. And stem cells is really a big category now. The word stem cells is used to describe a lot of different things. And so I've dropped a few things on this slide just to kind of explain the full spectrum. All of these kind of get termed stem cells, but are maybe a little twist on what that really is. So in the truest sense, the stem cells that are available here are really coming from two sources, either the bone marrow or adipose. And what we're going for are what's called the mesenchymal cells. Both of those processes require an extraction that's coming usually in some kind of type of procedure suite, an OR or an outpatient surgery type setting. Taking bone marrow or adipose can be a little uncomfortable. So it's a process, right? And then just like PRP, there are companies, right, and there's kits and systems that we use to really extract and get the highest quality elements, and they'll help us guarantee what the cell counts are for what we would inject. Something that's started to gain a lot of popularity now is these donated tissues. So usually amniotic or placentally derived process, but it's all perinatal. And if you think about it, right, this is going to be very, very high potency, right? Because this is coming from, from birth, right? And it's some of the highest potency you can get our hands on. So these are very rich in various growth factors that we know do accelerate healing and regenerative repair.
I talked to some docs that say the count. I know the count's important, and I don't know what the count is, but let's just say 20,000. You can tell me the real number is what they can commonly get here. But if you go out of the country, you can get a 50,000 count. And the other concern that I hear people talking about stem cells and getting them from placenta and embryonic cords, which seems like a great source. But some people are worried about, well, wait a minute, did the mother get vaccinated with an RNA vaccine? Because that could be altering things, and I don't want to be getting those altered stem cells into my body or my patient's body. Thoughts on that?
Yeah. So first of all, on the count side, the counts, higher is usually better, right? Whether it's 10, 20, 100, a billion, right? And that's what we're trying to kind of optimize usually. And what the systems do, if we're talking about the stem cells that are bone marrow or adipose, the systems help us really assure what those counts are. If it's donated, usually they're trying to process and freeze as quickly as possible to really maintain as many live cells as they can. The truth about these, though, we have no real idea how these things work. Is it the cells that are actually doing the work, or is it kind of the soup, so to speak, that they come in and it's more of a paracrine signaling? There's increasing evidence actually that it's more of a signaling type approach that's giving us the benefit, and so it's all of the other growth factors in the mix that's telling the stem cells what to grow and divide into. And so I think what we'll find over time is that the counts of some of the cells, for PRP, it's very important because it actually increases the density of the growth factors being delivered. But I think in the stem cell space, it's more about what is the concentration of the other signaling molecules, and because that's what's going to tell the local tissue to grow and divide. The stem cells themselves probably don't live very long once they're in a non-host environment. So as soon as we inject that into a rotator cuff or inject it into a knee, they're probably not living very long. They're certainly not dividing into the tissue that is the target tissue. So it's not like I inject bone marrow cells into a rotator cuff and those cells divide and become rotator cuff. What's happening is it's telling the local fibroblasts in the rotator cuff to lay down collagen and fill in that hole. It works maybe a little different than I think most people and certainly most patients expect that it's going to. The question on the RNA I think is really interesting, and there are actually for these donated tissues, there are companies that are specifically using are able to actually document the vaccine history of the mother, right? Or they will use only perinatal tissue from non-RNA vaccinated folks, and then there's a choice, right? You can actually get product that is from vaccinated or from non-vaccinated. So that's how we've kind of gotten around that. And I have patients for whom that's very important, right? And so we make sure that we kind of customize what we're using to what their preferences are. The last thing to talk about in the stem cell space is exosomes. Exosomes have been really emerging. And if you think back to your basic biology, cell biology days, exosomes are these vesicles that travel out of the cell, right? And they deliver actually a lot of these signaling molecules that we're talking about. And so a lot of folks are finding exosomes to be very beneficial, maybe even as beneficial as the stem cell. So the difference is we're just kind of processing out those vesicles as opposed to the cells. But ultimately, that's that paracrine signaling mechanism we were talking about. And it may be that with the exosomes, we're really just kind of concentrating the signaling element. So there's, I think, a lot of opportunity with exosomes in addition to or separately from stem cells. All these things can be combined, by the way. So I'll often do, most frequently actually, I'll do PRP with some sort of amniotic or placental allograft type treatment or an exosome treatment. and it bumps the volume because there's a lot of volume to the PRP. The stem cells come in very, very small volumes, generally speaking. So I can treat slightly larger areas and find that people tend to respond really well to that. It's sort of like augmenting the PRP or augmenting the stem cell treatment. So there's all kinds of things people do. That's the way I do it. And you can add hormones, you can add growth hormone, other things. So to me, if you're going to do this, right, we're throwing this is the kitchen sink, right? We're throwing everything at it. So these things can be combined. They can all be augmented together. So there's a ton of opportunities here, and we're still learning about it. I put in just kind of for reference. I didn't plan to go through the whole regenerative therapy slide, but the Sports Medicine Society came out with a position statement a few years ago that kind of helped just organize all of this, right? So just like I did with prolotherapy, PRP stem cells, all these other things coming out there. This literature is changing all the time. So for anybody who's interested, this article and this graphic from Clinical Journal of Sports Medicine in 21 it's a nice position statement, and just kind of helps give a nice overview for people. So kind of to summarize, and I've said this a few times, with ultrasound and regenerative medicine, they really are better together. So with ultrasound, the way that I'm thinking about it is, what's the diagnosis, right? What's the source of the pain that somebody really has, right? And so if we say, okay, now we've nailed that down, we may have injected with a little anesthetic and we've made their pain go away. Okay, now let's drop some regenerative treatment in there, as opposed to we call it spray and pray, right? Where you just inject and then hope you get a good outcome. And a lot of times you might, right? You inject PRP somewhere, you may get a really nice result, but this way we're being very specific, very precise, and really dropping the treatment exactly into the area of damage of that tissue. So I put in a little case because I thought it'd be nice to kind of talk through how this kind of could work in practice, right? So I have an example of a 38-year-old guy who was in a motor vehicle collision. He was a restrained driver, and he was T-boned. This was a real patient, T-boned. Another driver had, probably texting, just went right through the red light, hit him on the passenger side. So airbags all went off, and he got carted away, to the emergency room, and no head injuries, nothing broken, which is miraculous. The technology in cars now that, people in accidents like this 30 years ago had all kinds of different traumatic injuries. But now they have all this soft tissue stuff. And so he came into clinic a couple weeks later, and he's like, doc, my neck still hurts, and my shoulder still hurts. And it's like this, from here to here, right? It's like the whole thing hurts, right? So I was like, all right, we got to tease this apart and really figure out what's going on here. And so when we do the exam, no obvious defects. He's got tenderness just really globally. His whole neck is tender. And over the rotator cuff and AC joint, he's got tenderness in his shoulder. Range of motion's limited globally, right? He just doesn't like to move his head in any direction, really, which to me is triggering, right? Like he's trying to stabilize something, right? He's got some other soft tissue injuries deeper that he's trying to stabilize. And then the shoulder, he won't go past about 90 degrees in abduction and flexion. Strength is good. Some of it I can't assess, but neurologically totally intact to this young guy. And then his empty can is positive. So he just doesn't like it when I push on his arm and in a little bit of abduction. So the approach we took was with the neck was we needed to figure out what's the diagnosis in the neck, right? So we got an MRI to make sure there was nothing scary in there. And he had a bulging disc, but otherwise normal, right? And so you kind of look at the presentation and the MRI is saying, well, this looks pretty good, right? Like he's got this bulging disc, but generally speaking, normal imaging. And then his shoulder I scanned in the office, and he had a 4x5 millimeter articular sided partial thickness tear. So very similar to that supraspinatus defect that I showed in the imaging a little bit earlier. And so what we did is, because I wanted to kind of pick these things off one by one, right? I wanted to understand what's causing your pain. So we started with his rotator cuff, a little bit of anesthetic into that. His pain within a few minutes resolved. He was moving his shoulder. Great. But his neck, right? Neck is still painful, still a lot of tension there. So then we kind of worked our way up. I did a trigger point injection. And then trigger point injection helps relieve some of that spasm he's having in his trap and levator, and range of motion starts to improve, right? But not fully resolved. So there's still something going on in the cervical spine, right? Could be that disc, could be ligamentous injury. And so I know that there's basically kind of 2 or 3 things now here that we have to address for this gentleman. So what we ended up doing on him was prolotherapy, cervical prolotherapy. So we treat pretty much all levels, like all the way from like C2, where you can kind of get down. and to the beginning of thoracic spine to help create that biotensegrity concept we talked about earlier, that stability of the cervical ligaments in the cervical spine. We did a series of those. Usually that's what we do with prolotherapy, takes a few injections. Also repeated the trigger points a few times to help with the spasm and to break the spasm. And then we did guided PRP to that rotator cuff defect. So the PRP was a one-time deal. We had to do that once. And ultimately that gap fills in. It's amazing. We can scan it 3 months later and the hole is gone. And the patients love that, right? Because they can see that they did it. We did something, and then this was the result, right? It filled in. And then we got a lot of that stability back in his neck, and he was able to, and he was having, by the way, regular chiropractic care the whole time, right? So he was having his neck adjusted, he was having massage, he was having other things done by the other docs in the office. So this wasn't just me. And so at the end of this, right, he comes out feeling pretty much back to normal, right? And it took us a few months, but it's just to give you kind of a flavor of the type of thing that we do, or how we might think about a problem like this.
Well, it seems really nice because you're doing objective findings with imaging, exam, actual motion exam, and using your doctor skills to pinpoint this. Then you're doing a treatment. And then if you can do and the imaging is really reasonable, which is what you explained in the beginning, which is great, because if it costs low, it's good to do a pre and a post image, because now your objective findings are showing, oh yeah, the symptoms are better, and you can see on the imaging that it's healed up in there.
Yep. Yeah, that's exactly right. And it gets us to the answer quickly, right? Which we all know that there's patients that can kind of swirl a little bit in this world, right? And they end up with tons of imaging, but the imaging isn't being associated with the interpretation and integrated with that clinical exam to figure out, okay, now we understand what the imaging shows. How does that translate now to the patient's findings, the patient's symptoms, so that we know they're directing the treatment appropriately? And that's one of the biggest issues. So I just wanted to close by kind of giving like my philosophy, right? So the first is the patient totally comes first, right? So everything we're doing is trying to get the best possible outcome for the patient. The second piece is being very responsive, and that means to my colleagues, my other providers, and then also to the patients, right? And what they need. So being very available, sending documentation, sending notes, having the conversation with the other provider to say, this is what I'm finding. What are you seeing, right? That works so much better than the I did a thing. Here's my report. Sort of good luck.
Right.
And which goes to my last point, which is we are better together. I totally believe this. I think we all have our unique skill sets, right, that we bring. And so if you're a hammer, everything's a nail, and you need the perspectives of your colleagues to be able to really sort of have that different perspective, and I think really, really share in getting the best results for patients. So it really is what we've built at Optimize is a very collaborative model, but that is my intention with anybody else, right, that I get to work with to take care of a patient. That's a privilege. And so really want to do that in a way that's super, super collaborative with anybody that is trusting me and trusting us to be able to take care of those folks.
Well, Doctor, I think that's a great approach. That's what we try to do with everybody in the Whiplash group, is have that team approach, that we're all a piece of the puzzle to help this patient get to maximum medical improvement. And when we're documenting and we're communicating, like you're saying, rather than just even the reports, some people don't even share the reports. I think we should always, when we see a doc, send a report back to the doctor that referred him to us, so that we just have that congruency between the providers, which of course paves the way for the attorneys to just,
that's right,
they've got all the documentation. They need to really take care of that patient.
Yeah, we're just so much stronger when we communicate with each other. Yeah. And it's that little extra step, right? But it makes a huge difference for the care of the patients that we're seeing.
Absolutely. Well, I want to thank you for your time today, and I hope that doctors and attorneys both glean some great information from this, understanding the regenerative medicines better, understanding the imaging better, and how cost effective that is to use for patients, but especially in our personal injury world here. And I hope they reach out to you to help plug you into these patient care and cases, so that we can just help save more lives. So thank you.
Yeah, that's right. My pleasure. Always happy to connect with people, and thanks for the invitation. Happy being here.
Okay, and what's the easiest way for them to reach you?
So I'm at Optimize, which is in Murray, and so basically just reaching out to the practice. I can follow up with anybody that reaches out.